Hi everyone, I am Dr. Sandeep Sharma and I welcome you all to this discussion of INI CET May 22 questions. These are pediatric pattern questions and they are roughly based upon the recall given by students. Please remember that if there is a change in the language of the question, there is a change in the language of the options, or a word like accept has been omitted, obviously the answer will change. So you should more be focusing on the relevant discussion that I'll be doing. Wherever possible, I'll be discussing the respective reference also, because some of the questions, the answers may be controversial, and some of the questions, you will understand that the points being discussed, they are relevant for your upcoming exams, including NEET PG exam as well as for the future INI CET exams for those who will be sitting subsequently. So without wasting any time, let us begin with the discussion. Let us look at question number 1. So question number 1 was something like this: which of the following is associated with congenital absence of vas deferens and seminal vesicle? Among the four options, it is an easy one. It is cystic fibrosis, which is the correct answer. Cystic fibrosis is the one which is associated with absence of vas deferens and seminal vesicle in males. What are the proof? What is the references? Nelson clearly says that in 95, more than 95% of males, the body and tail of epididymis, the vas deferens and seminal vesicle are obliterated or atretic, resulting in male infertility. At a separate place, it also mentions that virtually all males are azoospermic. So complete male infertility is seen. Females have reduced fertility, but they are not completely sterile, right? So they are azoospermic because of the failure of development of Wolffian drug structures. So in the future, they may make a question like, instead of saying simply congenital absence of vas deferens, they may say which of the following disease is associated with aplasia of Wolffian duct structures. So this is how the questions can be slightly altered even if they are repeated. And thirdly, there is a entity, there is a term that you should understand. Nelson talks about an entity called as CBAVD. What is CBAVD? Congenital bilateral absence of vas deferens. This has been found to be associated with CFTR gene mutations, the same mutations which produce cystic fibrosis as well. Nelson very clearly says that it is among the most common non-respiratory manifestation. It is CBAVD in males and recurrent pancreatitis along with CBAVD. So if tomorrow you have a question, which among the following are the other non-pulmonary common manifestation? CBAVD, that is congenital absence of bilateral vas deferens, and recurrent pancreatitis. One of these may be mentioned in the option, and that may be your correct answer. So please remember these points. Otherwise, the answer is a simple one-liner. Question number 1, the answer is B. Moving to question number 2. Which of the following is a X-linked dominant condition? There are very few conditions which are X-linked dominant, and again, it's a more of a one-liner thing that you should remember, that it is Rett syndrome among the options given, which is a X-linked dominant condition. Rett syndrome has been frequently asked in the past papers of AIIMS entrance exam. What are the key points about Rett syndrome you should know? It is first of all X-linked dominant condition. Secondly, the gene mutated in this is called as MECP2 gene, which is present on long arm of chromosome X, specifically XQ28, right? These are majorly females. They are significantly more affected than males. So we say Rett syndrome is primarily a female condition because it is lethal for most males in utero. Having said that, certain males with Rett-like features can manifest, but most of them, Nelson says, they will not have deletion or mutation in the MECP2 gene. They will have a duplication. If males develop a Rett syndrome-like condition, they will have duplication of the gene, MECP2 gene, and it is a very rare condition. So for all practical purposes, these are females. The clinical features you already know. They grow normally till 1 year of age. After that, they have regression of the milestones. Majorly, the milestones related to vocal, that is language milestones, as well as motor milestones. These children can also have problems like ataxia. They can have problems like seizures. Generalized tonic-clonic seizures are present in more than 50% of these patients. And the hallmark finding of these patients are stereotypical hand wringing movements. Stereotypical hand wringing movements. Along with that, these patients are also found to have Microcephaly, we call it as acquired microcephaly because it tends to develop later after a normal development for a few years. So the points which I mentioned, directly or indirectly, if you look at past papers, you will find that these have been asked in one way or the other in various points. So all these points are extremely important. I'm not teaching you Rett syndrome, but key points I'm revising so that this video also acts as your revision tool for at least these topics which have been asked. So answer to question number 2 is C, Rett syndrome. Now, obviously, the question can be repeated in future and they may ask you what are the other X-linked dominant condition, or they may simply show you a pedigree chart and ask you the what is the type of inheritance. So if you have a picture like this is X-linked dominant. There are three things that you should remember. First of all, in a dominant inheritance, all the successive generations will be affected, right? So all the successive generations are affected, so it is a dominant condition. Why will you say X-linked dominant? Because two important considerations, two things are present in this. What are the two important things for X-linked dominant that you should remember? Whenever it is a affected female, whenever it is a affected female, she will be transmitting the disease to 50% of sons and 50% of daughters. So if she has two sons and two daughters, one son and one daughter will be affected, as you can see. So can you see that this is a female? So she's transmitting there to 50% of the total children. 50% of sons, 50% of daughters. So these two are affected here. If it is a affected male, you will find that all sons will be unaffected and all daughters will be affected. Most daughters are daddy's girls, and you can remember like that. So they will also get the disease in X-linked dominant from their daddy. Stupid way to remember, but anything works in the exams. So if you can see here, you will find that it is affected male. So this male is transmitting to both the female girls, the daughters, but the males are unaffected here. Can you see? So this is a condition called as X-linked dominant. So the next question which can be asked in your exam, what are the common conditions where X-linked dominant inheritance is seen? First of all, obviously Rett syndrome, on which question has been asked. Second is X-linked hypophosphatemic rickets. Third is there is a syndrome, there is a glycogen storage disease called as Dennon's disease. It is very similar to type 2 glycogen storage disease, that is Pompe's disease, but it occurs due to a different gene called as LAMP2 gene mutation. So Dennon's disease, इसका कोई numerical GSD 1, 2, 3, 4 ऐसा नहीं है, but it is very similar to type 2 Pompe's disease. So that can be a separate question also. It will have hypertrophic cardiomyopathy and skeletal muscle involvement and similar features similar to what happened in type 2 GSD. So Dennon's disease is also X-linked dominant. Then there can be problems in, there is a thing called as oculogenital digital syndrome. It is also mentioned in OPGAI. And then we have incontinentia pigmenti, which is considered to be a neurocutaneous disorder. So these are the 5 common conditions. There is a huge list, of course, but these are the 5 common conditions which you must remember for your exams. Without wasting time, let's move to question number 3. Which of the following is the best way to assess adequate response of ventilation during neonatal resuscitation? It is a repeat question. It has previously been asked. Improvement in heart rate is the best way to assess adequacy of ventilation. Whatever resuscitation you are doing, whatever positive pressure ventilation you are doing, if it is effective, there will be improvement in such oxygenation. This will improve the heart rate of the child which was going into bradycardia. NRP guidelines also very clearly say the most important indicator of successful positive pressure ventilation is a rising heart rate. So it is a repeat question, almost verbatim repeat, which has been asked. Moving towards the next question, question number 4. Which of the following amino acid does not need to be restricted in diet in MSUD? Maple syrup urine disease. Maple syrup urine disease is a condition in which there is defect in decarboxylation of branch chain amino acids like valine, leucine and isoleucine. So obviously dietary restriction will be needed for these 3. So leucine, isoleucine, valine, if you rule them out, what is the odd one out? Methionine, and that is your correct answer. What are the key last minute revision points you need to remember regarding MSUD? Let us have a look. Maple syrup urine disease. It is a condition which shows autosomal recessive inheritance. Question on it has already been asked about 5 to 6 years back. old thing, but again, anything which has been asked in the past can be repeated. Then you have, it is occurs due to defective decarboxylation. The word here is decarboxylation of branch chain amino acids, that is valine, leucine, and isoleucine. In the past, when JIPMER entrance exam used to be a separate exam, there was a question asked in, I think, 2017 or so, where they asked which is the most toxic in maple syrup urine disease, which causes maximum toxicity and disease manifestation. It is the accumulation of leucine which is found to be most toxic. Potential MCQ point, please add it to your notes if it is not already there. Then moving further, the cause is low activity of the branch chain alpha keto acid dehydrogenase complex. Then these patients will present in the neonatal period with the typical IEM-like manifestations like poor feeding, dehydration, acidosis, and cerebral depression. And maple syrup urine odor will be present. On this question has already been asked in the exam, and raised serum levels of these amino acids will be present. They will cause toxicity. Urine, if you add 2,4-DNPH, it will form yellow-white precipitates. And the treatment is hemodialysis or peritoneal dialysis, along with dietary restriction of these amino acids will be needed. Additionally, they may ask you which additional micronutrient supplementation can improve the symptoms. It is not curative, but it can improve the symptom. The answer is thiamine. Please remember this, again, a potential MCQ point. So this is maple syrup urine disease. Next, we come to question number 5. A child was born with the absence of thymus gland and congenital hypoparathyroidism. They showed you an image which was labeled as ABCD and asked कि किसके maldevelopment say it will produce. First of all, you need to understand what this syndrome, what this disease is we are talking about. A child having absence of thymus, absence of parathyroid. So there is maldevelopment of third and fourth pharyngeal pouches, and because of the third and fourth pharyngeal pouch involvement, which syndrome is produced where there is thymic aplasia, thymic hypoplasia, and hypoparathyroidism? Yes, it is 22q deletion syndrome. There is deletion in 22q11.2. The locus is very important. 22q11.2 locus is affected, and it produces a syndrome called as Dye-George syndrome. Dye-George syndrome, its sister syndrome, similar sounding syndromes with similar manifestations are many. You have Schroepinson syndrome, then you have villocardiofascial syndrome. They all are arising due to same gene deletion. So 22q11.2 is being talked about. So what was the structure which had been shown? Now have a look here. What you need to remember is that from the third pharyngeal pouch, you have inferior parathyroid and thymus arising, and you have the fourth pharyngeal pouch from where superior parathyroid gland arises. According to Nelson, according to Robbins 10th edition, according to Harrison, according to IAP textbook of pediatrics, all four agree that Dye-George syndrome arises because of maldevelopment of both third and fourth pharyngeal pouches. Now, if there is a question where they ask you to take side and pick one out of third and fourth, the better answer will be third. Strictly speaking, third and fourth both contribute to Dye-George syndrome, but because thymus is contributed majorly only by third pharyngeal pouch, and the question is very clearly saying that there is absence of thymus gland development, so if you have to choose one, the better answer will be third pharyngeal pouch, right? The word here is pouch, not cleft, not arch, because each pouch is present just below that arch. This is the first pharyngeal arch. Between first and second, you have the first pouch, and so on. So please understand, please remember the key words, what is being asked, what arch is being talked about, what cleft is being talked about, what pouch is being talked about. They are all separate entities, although we tend to take them together. So it is third and fourth pharyngeal pouch from where these arise. If you have to choose one, the better answer will be third. Since I don't have the labeled image, so that is all I can discuss. What I want to discuss here is what are the now the clinical features of Dye-George syndrome are likely to be asked in future exams, and they are important also for your for those who will be becoming residents in the future. So Dye-George syndrome, what are the key points that you should know? The clinical features are given by the mnemonic called as CATCH22. CATCH refers to the features and 22 is the chromosome which is involved. C stands for cardiac defect, which is the most common congenital heart disease in Dye-George syndrome. Very controversial. What I am telling here is based upon majority of pediatric literature. It says, very clearly says, interrupted aortic arch syndrome followed by truncus arteriosus followed by tetralogy of Fallot. So this is the sequence that you should remember. If that is not in the option, then truncus arteriosus will become your answer. A stands for abnormal facies. T stands for thymic hypoplasia, which leads to T cell immunodeficiency and recurrent infections. Then C stands for cleft palate. Cleft palate is the most inconsistent sign of Dijor syndrome. It may or may not be present. And then you have H, which stands for hypocalcemia, which occurs due to hypoplasia of the parathyroid gland. Please remember, there is also a old MCQ where they asked what is the first sign of Dijor syndrome. The first sign is a refractory neonatal hypocalcemia. That is the first clinical sign by which the child comes to attention in Dijor syndrome, right? Moving further, next we have question number 6. A 5 or 10-year-old male, depending upon the recall, he was admitted with complaints of fatigue and joint pains. On examination, a rash was found on the hands as shown in the image. What is the likely diagnosis? It is a very simple question. If you have revised your notes, irrespective of the coaching institute, it must have been taught to you that these are Gottron papules and they are seen in juvenile dermatomyositis. So answer to question number 6 is B, that is Gottron papule. Nelson describes them as pink to white colored, atrophic, shiny patches and plaques, which are present majorly on the dorsal surface of MCP joint, proximal and distal interphalangeal joints. So these are the exact pictures on which where these Gottron papules has been seen. There is also an entity called as inverse Gottron papule, which is seen on the palmar aspects between the digits. Inverse Gottron papule has a high risk of developing interstitial lung disease. So that is an additional point you can remember. But for this question, there is one point that I want to emphasize. It is a spotter kind of question, easy. But what is the key point that I want to emphasize? Since they have already asked juvenile dermatomyositis in the exam, in future they can ask you what is the diagnostic criteria, or they may give you a long clinical case and you may be asked to tell the diagnosis. So what is the diagnostic criteria? First of all, there should be either one out of these two things. Either there should be a rash, what you call as heliotrope rash. I hope you know what is a heliotrope rash. It is a purple colored rash present majorly in the periorbital region, more on the upper eyelid region, or there should be Gottron papules, as I have just shown. Presence of either heliotropic rash or Gottron papules plus any three of the following should be present. Any three of the following. There should be proximal myopathy. This proximal myopathy will manifest in the form of, it may cause a positive Gauver sign. So Gauver sign is not only seen in patients of Duchenne's muscular dystrophy, it can also occur in JDM, that is juvenile dermatomyositis. Secondly, there will be increased in the serum creatine phosphokinase levels. Thirdly, there will be evidence of myopathy on EMG, for example, fibrillations. And fourthly, there will be evidence of muscle biopsy evidence showing myophagocytosis or similar features which have been described for juvenile dermatomyositis, right? So presence of either one of this or this plus any three of these four features, it is diagnostic of juvenile dermatomyositis. Very important. Please add it to your notes. It is there in Gahi also. It is mentioned in Nelson also. It indirectly, it has been framed as a part of clinical scenario in the past. Moving further, question number 7, very controversial, but there is a good evidence for the answer to this question. For a preterm child, what is best suited in the absence of breast milk? For any child, including preterm, mother's milk is the best. If mother's milk, her own mother's milk is not available, the second best option is donor's milk. Please remember that. In the absence of breast milk for a preterm child, it is the donor breast milk which should be pasteurized and given to the child, because end of the day it is also human milk. Human milk is always safe than any artificial milk or any animal milk. If that is not available, the second best will be preterm formula milk. Contrary to popular perception, animal milk comes in the end and it should be undiluted cow's milk. Obviously you will reduce the fat, so low fat undiluted cow's milk. Do not add water. Any water added to any milk, that is not to be given. So the best milk among the option given is donor milk, and that is your correct answer. So what is the evidence for this? The evidence is very clear. Look at this. This is taken from World Health Organization. WHO website latest review. It says WHO, American Academy of Pediatrics, ESPGHAN, which is the standard guideline जो सारी guidelines pediatric GIT की frame करते हैं इंडिया में, and all national and global policies call for the use of donor human milk as the feeding of choice if mother's own milk is insufficient, unavailable, or contraindicated. It is somewhat inferior to mother's own milk but superior to infant formula. So donor human milk is always superior. And in fact, if you read further, the article further says that preterm children, you need to understand why are we not using other milk, because other milks have a risk of introducing infection, causing necrotizing enterocolitis. It has been found in multiple meta-analysis. जब चारों को compare किया, it is found that donor breast milk has least risk of necrotizing enterocolitis and feed intolerance, and that is why it is best suited in the absence of the child's own mother milk being available, right? So question number 7, C, donor breast milk. Moving further, question number 8. Which of the following is the recommended dose for HPV vaccine in girls aged 9 to 14 years according to WHO's age protocols? It's a very controversial thing. It has also come into attention recently, and that is why this question has been framed. Classically speaking, as of now, the current protocol says there are multiple types of HPV vaccines. You have bivalent, quadrivalent, and now nonavalent vaccine is also coming. For all these patients, if it is 9 to 14 years, you will be giving 2 doses with a gap of 6 months. This has been the current recommendation. But something changed on 11th April 2022. 11th April 2022, WHO SAGE protocols were revised. And what did they say? They were not exactly revised. There was a meeting. And that meeting said the following. It said that 1 dose schedule is equally potent as 2 dose schedule for girls aged 9 to 14, and even for young women aged 15 to 20 you can use 1 day schedule. With HIV patients, obviously 3 doses should be given, but they clearly said that this is just a opinion of this side and it is not a recommendation or change in the protocol. They said the WHO recommendation will be updated following further consultation across stakeholders. So as of now, the answer to this question, the better answer to this question after I discussed with 2 of my colleagues, was 2 doses. But as soon as the WHO protocol changes and recommendations are implemented, the answer is likely to become 1 dose. Right now they are saying 1 or 2. They also mention in the, if you read the entire document, they very clearly say that as of now, the previous protocol which said that 2 doses should be followed, it should be continued till everybody comes on board and recommendations are mentioned. Opinion is different from recommendation. Please understand that. I saying something or a group of people saying something is opinion. Something being written in hard word, level of evidence being mentioned, that is recommendation. Recommendation is still 2 doses, because there are a lot of controversy on this. So I'm spending some time trying to explain this point. You can always forward in case you want to in case you are revising. So moving further, we have question number 9. 4-year-old male child with body weight of 15 kgs and height 100 centimeters is admitted with renal failure. His blood urea was 100 milligram per deciliter. Serum creatinine was 1 milligram per deciliter. What is the closest calculated EGFR in the patient? There is a formula called as Schwartz formula. This Schwartz formula is also mentioned in OP-Ghai. It is also mentioned in Nelson. Schwartz formula clearly says that estimated GFR of a child is given by the formula K, where K refers to a constant value, multiplied by height of the child in centimeters, divided by serum creatinine in milligram per deciliter. So what it means is there is no role of urea, there is no role of body weight in calculating this, and also the age of the child. So what is the formula for K here? Most centers say, Nelson clearly say. Now there is a slight controversy on this also. We'll keep it simple. Indian children, different age related criteria have been given. However, the original formula and the one which is mentioned in both Ghai and Nelson, it very clearly says the value of K is about 0.41. So 0.41, if you multiply by 100 and divide by serum creatinine, which is 1, what is the value you get? 41 ml per minute per 1.73 meter square body surface area. What is the closest calculated EGFR in the patient? The closest value they are asking, not the exact value, that is B, that is 40 ml per minute per 1.73 meter square body surface area. There are catch in this question that in Indian children, recent studies show there is a textbook of pediatric nephrology which says that in Indian children between 1 to 12 years, above 1 year of age, the value of K should be changed. It should be about 0.55. However, Nelson does not agree on this, and even OPGI 9th edition, the latest edition, it clearly says it should be 0.41, and so we will stick to, again, not opinion, but what is mentioned in the textbooks, standard textbooks. It is 0.41, and the answer to the question is B, which is the closest answer. Moving further, next is question number 10. ACTH is used in the treatment of which of the following? Now, this is one question I think most of you would have got it right. It is a very frequently asked question. It is a kind of a repeat question as well, another repeat which was asked in the exam. But there is a reason why this repeat was asked, because the management guidelines of West syndrome have been updated in 2021. We call them as AOCN guidelines 2021. So I'll be briefly sharing the summary with you. It can be a potential future MCQ as well. More complicated question. The answer to question number 10 is obviously West syndrome, that is C option. So what are the summary key points you should remember? Management of West syndrome. Therapy of choice is hormonal therapy. In hormonal therapy, ACTH, adrenocorticotropic hormone, is the preferred agent, and high dose regime is used. There are multiple types of regime, among which high dose regime, this word is important for your exam. So you may get a question where two options are ACTH low dose, ACTH high dose. The answer will be ACTH high dose regime. And this is the dose that you can remember. It is given intramuscularly OD for 2 weeks. And if it is not available because it is a costly agent, you can use prednisolone also for 2 weeks, although ACTH is preferred over prednisolone. And vigabatrin is alternative agent. Vigabatrin is used where hormonal therapy will be unavailable or contraindicated, and vigabatrin is the preferred agent if it is associated with, the West syndrome is associated with tuberous sclerosis. And 30% cases of vigabatrin patients, they tend to develop retinal toxicity. And that is why they may give you a question, scenario type question. They may ask you, a patient with West syndrome is well controlled on vigabatrin. Which assessment needs to be done in the child? Periodic monitoring needs to be done of which part? Ophthalmic examination repeatedly, usually 6 to 12 monthly, will be needed in all of these patients, right? So this way, the key words you need to remember. Also remember that when you say West syndrome, if you talk about the classic triad of West syndrome, it includes infantile spasm, EEG showing hips arrhythmia, and mental retardation or intellectual dysfunction, right? But if the question says, what is diagnosis of West syndrome? For diagnosis, presence of mental retardation is not mandatory. Presence of clinical infantile spasm with EEG showing hips arrhythmia or its variant is sufficient enough for diagnosis to be made. Please remember this key point. This is additional thing which has been very clearly mentioned in the new guidelines. Moving further, some of the additional therapies that you should know, at least the names. If both hormonal therapy and vigabatrin fail, it does happen in some individuals. You can give benzodiazepine, valproate, topiramate, or zonisamide can be given. Dietary therapy like ketogenic diet can be tried. If either hormonal or VGB plus one additional drug out of these four are failing, you can start ketogenic diet, give a trial for 3 months. If that is not available, a modified Atkins diet can also be tried. And in case there is a West syndrome associated with a surgically correctable lesion, this only MRI will tell you. In these patients, you will have to perform epilepsy surgery. So these example will include cortical dysplasia and structural anomalies seen in neurocutaneous syndromes. Moving further to question number 11. 1-year-old boy brought to you for vaccination. He has only received one shot of DPT at 6 weeks. What should you do now? Very clear. Among all the primary vaccines that we give, in which if the primary series gets interrupted, you should not restart it again, provided the previous dose had been given at the proper site in the proper dose. Here we assume that it was given in the proper dose at 6 weeks. You will give the second dose whenever the child comes to medical attention. So give second dose of DPT shot is the correct answer. You do not restart the therapy. Now the examiner may ask you, what is the reason for, what is the basis for this thing? There is a concept, there is a term that you must remember. I'm writing in capitals, called as immune memory. Immune memory is a phenomena which ensures that even if a single DPT vaccine has been given, even if the next dose gets delayed by a few months or probably even years, still the response to that is not lost completely. The subsequent doses, if you catch up the vaccine, the catch-up schedule is followed meticulously, and the booster is given after at least 6 months after the last dose, the third dose of DPT has been given. Almost equivalent response can be seen in the patient. I'm saying almost equivalent because obviously it will be less, but it will not be totally gone. Because of this immune memory phenomena, patients with DPT, even if they get interrupted, whenever the patient comes to you, you will give the second dose of DPT. You will continue from where you had left. This is mentioned in the IAP publications also. This is mentioned in Park's PSN textbook as well. Moving further, question number 12. 2-year-old male child admitted with recurrent bloody stools, atopic dermatitis like rash and petechiae. TLC is normal and platelet count is 20,000. So what are the things the child is having? The child is having recurrent bloody stools, can be recurrent diarrheas, mucosal infections can be there. Along with that, the child is having thrombocytopenia and the patient is having eczema like rash. So the diagnosis, first of all, in this patient looks to be Wiskott-Eldridge syndrome. Since it is a male child, this point will also add to it. In case the gender was not mentioned, still Wiskott-Eldridge syndrome looks to be the most likely possibility. Male child, why? Because Wiskott-Eldridge shows X-linked recessive inheritance. So what is the next best step to establish the diagnosis? You will screen for VASP expression. So what are the key words related to Wiskott-Eldridge that you will remember? If you look at past papers, in NEET PG exam in the last 4 years, 2 times Wiskott-Eldridge has already been asked. So key points, let's summarize before we go to the next question. So these points I've taken from Nelson, Ghai and past papers. So Wiskott-Eldridge, inheritance is X-linked recessive, short arm of chromosome X, that is XP11.2223. The gene is VASP gene. It codes for a protein called as Wiskott-Eldridge syndrome associated protein, which binds to CDC42H2 and RAC, which are a type of GTPases. They are involved in the process of actin filament assembly as well as in signal transduction in the immune cells. So if this protein gets decreased or it becomes absent, obviously all this phenomena will be affected and the patient will develop a classic triad of eczema, recurrent infection and thrombocytopenia with small size platelets leading to bleeding manifestation. And this is a classic image of bilateral eczema like rash along with thrombocytopenia, which will happen in a male child. So what are the other key points regarding investigations that you should know? First of all, the platelets are small in number as well as in size, and there is low IgM in the patient. IgA and IgE are elevated and IgG levels are usually normal. Nelson says some of the patient can have slightly low IgG, but it is not low enough to cause any specific problems. It is the low IgM along with immune dysfunction which is responsible for all the recurrent infections. Now for screening and diagnosis, the guidelines clearly say for screening we use flow cytometry analysis of VASP protein expression in all of these patients. In case you find it is not feasible or any doubt in these patients, you can go in for VASP gene analysis. Here protein analysis kar rahe hain pehle. If that is not possible, the gold standard is VASP gene analysis, which will tell you the exact mutation also and the degree of mutation, how severe the mutation is. Treatment in these patients is obviously hematopoietic stem cell transplant is the therapy of choice, right? Let's move further. Question number 12, obviously the answer is B. We have question number 13. Tongue fasciculations are a feature of which among the following? Now, this question can come in medicine also. This can come in pediatrics also. It's an overlap question. And the answer is, because the answer is a pediatric condition, so I've included it here. And some key points I want to emphasize. Tongue fasciculations basically show denervation of the group of muscles which are being supplied. And it is this denervation is usually a sign of motor neuron disease. Which is the motor neuron disease among them? The answer is spinal muscular atrophy. Why? Spinal muscular atrophy is a condition where there is progressive involvement of the anterior motor horn cells of the spinal cord, which leads to progressive denervation. So all the skeletal muscles are supplied by them. Initially, they become hypotonic, and then as denervation proceeds, you will find that fasciculations tend to happen. These fasciculations are earliest observed in tongue. So whenever you have a question where the diagnosis or the question is saying there is an infant which is floppy. So whenever there is a floppy infant in the question in a future, you can write these points for quick revision. Floppy infant having tongue fasciculations. They may not directly say floppy infant. They may say the child was having, on examination, there was hypotonia and rag doll posture or frog leg posture was rag doll or frog leg posture was seen in the child along with tongue fasciculation. You should suspect spinal muscular atrophy as the one possibility. Right? SMA is of 5 types actually. There is a type 0 which is lethal in utero, type 1 which is Werdnig-Hoffmann disease which comes to attention in the first 6 months. Then we have type 2, 3 and 4 which as the number increases, the severity comes down, and the type 4, the last one, it has the adult onset. Right? So Werdnig-Hoffmann disease is the classic one which will have tongue fasciculations. So what are the other additional points that you should know? Nelson says that fasciculations are a specific clinical sign of the denervation of muscle. They are best observed in the tongue. Why? Because there is no subcutaneous connective tissue separating the muscular layer from the epithelium. And O.P. Ghai says that children, Werdnig-Hoffmann disease, that is type 1, they present with profound hypotonia, flaccid weakness and global reflexia, respiratory weakness, poor swallowing and tongue fasciculations are common in them. So the answer is B. Moving further, Not useful in the management of hyperkalemia. So whether it is a child or adult, the management principles remain the same. In hyperkalemia, the first step is always to prevent life-threatening arrhythmia. So first step is always giving IV calcium gluconate. Calcium gluconate, please remember, does not reduce serum potassium level. The serum potassium is not affected, it only stabilizes the cardiac membrane. Then you try to, as a second step, you try to reduce the serum potassium levels. This serum potassium level reduction can be done by making potassium go into the cell, inside the cell. And what are the three ways it can be done? It can be done through salbutamol, also called as albuterol nebulization. You can do it through sodium bicarbonate, which is given in a dose of 1 milliculant per kg. Especially if the patient is having acidosis, sodium bicarbonate will be very effective. With hyperkalemia, if it will be there. And thirdly, you will use insulin glucose infusion. In chronic hypokalemia, to reduce the total body potassium, you can use potassium exchange resins like polystyrene sulfonate, that is KXLate also, but it will not be useful in acute condition. So if they say what is the first step, calcium gluconate. Calcium gluconate does not reduce the potassium levels, but it stabilizes the membrane. These are the three things which reduce serum potassium level. You can use either one or more of these or a combination of these. And for chronic hyperkalemia, reducing total body potassium, you will use resins, right? So what is the odd one out here? Not useful in the management. IV magnesium sulfate is your answer. Moving to question number 15. Interesting question. Which among the following is not useful in the management of sickle cell anemia? Let us look at what the evidence is. Hydroxyurea is one of the most commonly used agent both in children and adult for sickle cell anemia. So what is the evidence? Nelson clearly says that hydroxyurea is a myelosuppressive agent. It has been found useful and requirement for blood transfusion in adults also, and it has been found useful in children also. In fact, children from 9 months of age onwards with sickle cell anemia, you can start hydroxyurea. Nelson also says that FDA has approved oral L-glutamine as an add-on agent in patients at or above 5 years of age, and it has been found to reduce the risk of sickle cell crisis. So D cannot be the answer, A cannot be the answer. Question is saying not useful, not word is there, right? What we are left with is voxelotor and bebtelovimab. Voxelotor is a very important drug. It is the world's first hemoglobin oxygen affinity modulator. It is the world's first hemoglobin oxygen affinity modulator. It was approved by FDA in 2019 for adults, and it was approved in 2021 November, December, as recent as few months back for children above 4 years of age. And that is why this option was included in this. What we are left with, so voxelotor is useful in patients of sickle cell anemia, and its exact role still needs to be defined, but it has been approved by FDA and it is being used in some tertiary care centers. So what we are left with, bebtelovimab. Bebtelovimab is the answer here. It is not useful in the management of sickle cell anemia. It is a monoclonal antibody useful in COVID-19 infection. Both adults as well as children above 12 years of age, it has been recommended by FDA, and recent studies have shown it is effective even in Omicron variant of COVID-19. So the question arises, what are the patients in which this is to be given? Patient with any risk factor with mild to moderate COVID infection where there is a risk of progression to serious disease, right? So bebtelovimab is not useful in sickle cell anemia. It is useful in COVID-19, recently approved COVID-19 monoclonal antibody. Now we move to question number 16. The options could not be recalled. What is the ectopic tissue found in Meckel's diverticulum? There were various options which were given, and the answer to that was gastric and pancreatic tissue. What are the key words regarding Meckel's diverticulum that you should be remembering? There is a rule of twos in Meckel's diverticulum. It is seen in 2% population. It is 2 inches in length. Present 2 feet proximal to ileocecal valve along the antimesenteric border, 2 times more common in females than males with a ratio of 2:1. 2 types of ectopic tissues are commonly found, that is gastric tissue followed by pancreatic tissue. Different books place one over the other, but in general we say gastric and pancreatic. This is the sequence which is mentioned. If somebody asks you any other type of tissue which is also present, yes, jejunal tissue is also commonly present, but most commonly are gastric and pancreatic tissues. And last point, it presents before 2 years of age. So this is the rule of two in Meckel's diverticulum. We have been remembering rules of two since the beginning, since our surgery days in MBBS. Still, we forget, and still we get this question wrong. So if you have seen all these questions, you would realize that it is not very rare things which make you mark wrong in the paper. It is the expected things, how good you are with updates, how good are with your accuracy, and how well you have revised all aspects of a particular subject, rather than reading something very aggressively and not doing something at all. So a balanced approach can crack INI-CET, and this same balanced approach will be useful in your NEET PG exam as well. So revise well, and I hope the result is favorable to you. All the best for your exams. I again say in the end, the answers, the question, the discussion is based upon the recall. If the language of the question changes or additional information come, obviously the answer will change. So this is from me, Dr. Sandeep Sharma. Any queries, you are most welcome to ask again. Thank you very much. All the best for your exams.